Hello, my name is Lydia Petricca, and I'm a graduate student in the Bullock and Price Labs at the University of Virginia. And I will be presenting on combining thermal ablative focused ultrasound with gemcitabine to immunologically control triple-negative breast cancer, how it works. So metastatic breast cancer is the second most prevalent cause of cancer mortality in women in the United States. Triple-negative breast cancer, or TNBC, as I will refer to it throughout this talk, is a subset of breast cancer in which the tumor cells are lacking the expression of estrogen and progesterone hormone receptors, as well as the human epidermal growth factor HER2 receptor. TNBC makes up about 20% of all breast cancer cases. This disease can inflict a high metastatic burden, and it has been shown to spread to various organs throughout the body, including the lungs, brain, bone, and liver. When compared to other breast cancer subtypes, TNBC has a poorer prognosis. For example, stage 4 TNBC has a 5-year overall survival rate of only about 22%, which is significantly lower than that of other stage 4 breast cancer subclasses. As we know, current breast cancer treatment strategies are often highly invasive as they involve surgical resection of large portions of the patient's breast tissue. So this is where the use of focused ultrasound as a therapeutic comes into play. Specifically, my presentation will be focused on the use of thermal ablative FUS as a therapeutic for TNBC. And as we know, there are multiple benefits of using FUS as a therapy, as it is non-invasive and non-ionizing. It can be utilized repeatedly without decreased efficacy. It has been shown to enhance drug delivery, chemotherapy, and radiation sensitization, and it can lead to the immunomodulation of the tumor microenvironment. So the model that we use to depict TNBC is the 4T1 syngeneic mouse model, which is commonly used preclinically because it resembles human TNBC in its poor immunogenicity and its ability to spontaneously metastasize. Also depicted here is a schematic outlining our FUS treatment regimen. So the first question that our lab set out to answer was whether FUS as a monotherapy could control TNBC outgrowth. So to answer this, we implanted 4T1 tumors into biopsy mice and treated the tumors with FUS 14 days later. And tumor outgrowth and survival was measured over time. When we compared FUS-treated 4T1 tumors to sham control tumors that were not treated with FUS, we observed no difference in tumor outgrowth and overall survival. So this made us wonder why we wouldn't be seeing control of TNBC even though the tumors are being ablated. So this led us to look at immune cell populations within the tumor microenvironment, as some immune cells can act in an immunosuppressive and pro-tumorigenic manner. Upon performing flow cytometry on FUS-treated and untreated tumors, it was found that granulocytes are the most abundant immune cell type within the 4T1 tumor microenvironment, and FUS treatment does not alter the presence of these cells. So granulocytic myeloid-derived cells have been shown to exhibit immunosuppressive function in the context of cancer. This led us to look at combining our FUS treatment regimen with the chemotherapy gemcitabine, as gemcitabine is a clinical standard of care therapy for numerous cancer types, including breast cancer. Additionally, gem has been shown to have myeloablative effects on GR1 positive cells in the 4T1 model. So we were interested in determining if combining gem with focused ultrasound would provide a therapeutic advantage against TNBC. And yes, we found that when we treated 4T1 tumor-bearing mice with both thermal ablative FUS and gemcitabine, primary tumor growth was significantly inhibited and overall survival was significantly extended when compared to the sham control group and the monotherapy cohorts. To summarize thus far, I have showed that FUS monotherapy is ineffective in controlling TNBC, that granulocytes are the dominant immune cell type in the 4T1 tumor microenvironment, and that FUS treatment does not alter the presence of granulocytes in the TME. Combining FUS plus gem therapy for TNBC can transiently control primary tumor growth and lengthen overall survival time. So our overarching goal is to understand mechanistically how FUS plus gem are working together to constrain TNBC. So a hypothesis we have is that given the prevalence of granulocytes from the 4T1 tumor-bearing mice, we hypothesize that gem is depleting granulocytic cells, resulting in immunosuppression alleviation. So to begin addressing this hypothesis, we first wanted to determine how gem is impacting circulating myeloid-derived cells. To answer this question, we performed a time course experiment in which 4T1 tumors were implanted into biopsy mice. We administered an injection of gem or the vehicle control on day 14, which is consistent with our FUS plus gem treatment regimen. The mice were then bled 24 hours, 96 hours, and 7 days post-injection. And a naive, non-tumor-bearing biopsy mouse was also bled as an additional control for tumor-induced myelopoiesis. The blood was processed and stained for flow cytometry to assess the effects of GEM on circulating immune cells. So our initial hypothesis was that GEM is depleting granulocytic cells. So to determine whether this was the case, we looked at differences in the presence of Ly6G positive and Ly6C mid myeloid cells. So compared to the naive non-tumor bearing mouse, myelopoiesis was evident in 4T1 mice regardless of injection. But when we focus on the granulocyte gate outlined in red, we observed no difference 24 hours post-injection in the percent of live immune cells that are granulocytes between the control and the GEM-treated mice. However, following injection, a significant reduction in the percent of granulocytes in circulation is observed in the GEM-treated mice. By day 7 post-injection, the proportion of granulocytes in the GEM-treated mice has restored to the level of the control mice. The same trend was observed when we looked specifically within the myeloid compartment. Interestingly, when we were analyzing the blood samples for the granulocytic cells, we noticed that at the 24-hour time point, there was almost a complete loss of Ly6C positive monocytic cells in the GEM-treated cohort. However, by 96 hours, this population had reappeared in the blood of GEM-treated mice. And by day 7 post-injection, the proportion of monocytes in the GEM-treated mice had restored to the level of the control mice. So again, the same trend was observed when we looked specifically within the myeloid compartment. So the half-life of gemcitabine within a mouse is very short, and only about 17 minutes. However, we do not see a reduction in circulating granulocytes until day 4 post-injection. And it is not until after the depletion of monocytes, which occurs within 24 hours following injection, that we see a loss of the granulocytes later on. And by day 7 post-injection, both cell types have restored to control levels. So this could suggest that the presence of the monocytic cells is required to support the granulocytes. To summarize, we observed that the chemotherapy gemcitabine acutely depletes monocytic cells, and that 96 hours post-injection, GEM induces a significant reduction in the proportion of granulocytes in circulation. This could suggest a potential interplay between the monocytes and the granulocytes. In the future, we would like to perform functional analysis on these monocytic and granulocytic cells in circulation and within the tumor microenvironment to determine if they are acting as a barrier to anti-tumor immunity. We are also interested in characterizing the effects GEM is having on myeloid cells in the TME. Lastly, we would like to assess whether the effectiveness of FUS plus GEM combinatorial therapy is mediated by granulocytic depletion by using a monoclonal antibody to specifically target Ly6G positive cells. With that, I would like to thank my lab members, specifically Andrew Tim, and past members Natasha Shabani and Ali Witter, who have helped immensely with this project. Thank you to Drs. Bullock and Price for providing feedback and mentorship, and thank you to my thesis committee for providing constructive insight into my research. Thank you to UVA's Immunology Training Grant for funding my research, and thank you to you all for your time.